Chemotherapy. Chemotherapy uses anti-cancer drugs to target and destroy cancer cells throughout the body. It is often used as an alternative or addition to surgery for bronchial carcinoma and mesothelioma. For bronchial carcinoma, chemotherapy may be used before surgery, neoadjuvant chemotherapy, to shrink the tumor and make it easier to remove. It is also commonly given after surgery to kill any remaining cancer cells, adjuvant chemotherapy. For unresectable mesothelioma, chemotherapy is the main treatment option. Platinum-based doublet or triplet chemotherapy combinations are most commonly used. Some examples include cisplatin with pemetrexed or carboplatin with pemetrexed. Chemotherapy is also an option for recurrent or advanced disease when surgery is no longer an option. Radiation therapy. Radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells or slow their growth. It is not usually used alone but is commonly combined with chemotherapy as an alternative or addition to surgery. For bronchial carcinoma, radiation therapy may be given before surgery, neoadjuvant therapy, to shrink the tumor after surgery, adjuvant therapy, to kill any remaining cells. For mesothelioma, radiation therapy is typically used for palliation of symptoms from locally advanced tumors like pain or bleeding that cannot be resolved by other means. It can also sometimes be used immediately after tumor debulking surgeries. Common radiation therapy techniques include external beam radiation, internal radiation therapy, brachytherapy, and stereotactic radiosurgery. Targeted drug therapy. Targeted drug therapies block the growth and spread of cancer by interfering with specific molecules, molecular targets, that are involved in the growth, progression, and spread of cancer. They cause less harm to normal cells. Some targeted drugs approved for pleural mesothelioma include bevacizumab, Avastin, pemetrexed, Alimta, and rindapepimut, Rintiga. For advanced non-small cell lung cancer, targeted therapies like erlotinib, gefitinib, afatinib or crizotinib may be options depending on the mutation status of the tumor. Targeted therapies are usually given along with chemotherapy for advanced disease when surgery is no longer an option. Clinical trials. Enrolling in a clinical trial of new drug therapies or treatment combinations should be considered, especially for advanced mesothelioma or bronchial carcinoma that has recurred after initial treatment. Phase 3 clinical trials investigate new drugs or approaches and may offer opportunities to access promising new treatments before general approval. Trials help advance the field by collecting data on safety and efficacy. Participation is voluntary but clinical trials can potentially provide access to cutting-edge therapies not yet available outside of a research setting. Photodynamic therapy, PDT. PDT involves injecting a light-sensitive drug that accumulates preferentially in cancer cells called a photosensitizer. A few days later, a special light is shown on the tumor area, which activates the drug and produces an active form of oxygen that destroys nearby cancer cells through a process called photodynamic action. For early-stage lung cancer near the surface, intrapleural PDT involves injecting the drug into the pleural space. It is mainly investigational at this time but may offer an alternative or addition to surgery or radiation therapy in selected cases. Lung ablation techniques. Minimally invasive image-guided techniques like radiofrequency ablation, RFA, microwave ablation, cryoablation or irreversible electroporation can be used to apply targeted energy that destroys solid cancer tumors through heat, cold or electric current pulses, respectively. These local ablation techniques are sometimes used to treat small peripheral bronchial carcinomas as an alternative to surgery, especially in high-risk patients who cannot tolerate an operation. They may also play a role for palliation of symptomatic mesothelioma tumors. Primary tumors as large as 3 to 5 centimeters have been ablated in some cases. Careful patient selection is important as effectiveness depends on tumor size and location. Watchful waiting. Active surveillance. For some early-stage, slow-growing mesothelioma tumors or incidental small lung cancers found unexpectedly on scans, for example subsolid nodules, an initial period of active surveillance without immediate intervention may be recommended. The patient is closely monitored with follow-up CT scans every 3 to 6 months to check for any sign of growth or progression. If stable over time, continued observation without treatment remains a reasonable strategy to avoid unnecessary risks from invasive procedures for indolent lesions unlikely to cause harm or symptoms in a patient's lifetime. Surgery or other local therapies can still be considered if future growth occurs. Palliative care. For advanced mesothelioma or bronchial carcinoma that is no longer curable, palliative care aims to reduce suffering and improve quality of life through comprehensive, multidisciplinary treatment of symptoms like pain, shortness of breath, weight loss, mood disorders and other side effects from the disease or its treatment. Palliative care is always recommended alongside curative therapies like surgery but is especially important for end-of-life care when the main goals shift to maximizing comfort and function rather than life prolongation. It involves a team-based approach including medical care, counseling, nutritional and spiritual support to address physical, emotional and practical needs. While surgery remains a mainstay treatment option when possible, there are now many alternatives and complementary approaches for bronchial carcinoma and mesothelioma that may offer reasonable palliation, disease control or improved outcomes depending on the individual clinical circumstances. A multidisciplinary team is invaluable to carefully evaluate all options and develop a personalized, evidence-based treatment plan tailored for each patient's unique situation and priorities.